very much for that very nice introduction. This is a tough talk for me because I've been asked to prioritize, and pathologists just want more and more and more and more tissue. Then we want to store it someplace where we can never get it, and then when you ask for it, we don't want to give it to you. So this is a little bit challenging for me to actually try to save tissue. Now you didn't tell me how to advance.
The green.
Ah, the green. The green. The green. No, okay. What I really think about testing for mutations is that there are no histologic or clinical surrogates for mutation testing. So I don't think that we should use age, gender, ethnicity, smoking history. I don't think there's anything that we should use to stop from testing adenocarcinoma. So in our institution, if you have adenocarcinoma, you get tested. That's it. Now, we as pathologists don't use the term non-squamous because it's not really a pathology classifier, although we've come to understand that it's important to clinicians who want to choose therapy based on histology or mutation status and want to know who to study. So we will study all non-squamous carcinomas of the lung. Now, what do we mean by that? We want to study adenos, but sometimes we can't decide that it's an adeno, or we're afraid that we're looking at a component of an adenosquamous tumor and we're not seeing full representation, or sometimes it doesn't make sense. 19-year-old never smoker with squamous cell carcinoma. So we recognize that there are limits to what we can do. Not many, but there are some limits to what we can do with the microscope. And so if we cannot say that it is squamous, we will test it. We believe that giving tyrosine kinase inhibitors to patients with that mutations is harmful, and I'll let you refer to the appropriate studies yourself to verify that. We do something that's called reflex testing. I like to make a joke and say that I should have called it Zukowski testing, but I didn't, and now it's reflex testing. And a lot of people talk about reflex testing, or their institutions do it, or they're thinking about doing it, but I don't know if they understand what we mean by that. This is based on a model that was very familiar to me as a cytopathologist, where when we look at pap smears and we see changes in the squamous epithelium that we think are indicative of HPV infection, but we're not quite positive, we send that for things such as hybrid capture, analysis of HPV. We don't ask anyone, should we, can we? We don't wait for someone to ask us to. We see these changes and we reflexly move it on. And so that's what we do in the lung. We don't ask for a clinical order or a discussion or a request. We see something under the microscope that we think could potentially yield up a targetable mutation on analysis, and we test it. And it's as simple as that. Now, we test for a number of different abnormalities. We're using sequenome right now. We're transitioning to next gen. So we will test for a number of things that perhaps the oncologist has not ordered, but the cost is the same whether we test for EGFR, KRAS, or we do a whole panel on the sequenome. We believe that the method that we use to test these things is up to our laboratories individually. We think that the laboratory should make this decision at a local level in conjunction with perhaps administration, perhaps with oncology, who's going to pay for it, that kind of stuff. But we think that it's up to us to decide how to reflex the specimens. And so we mean by reflex that while there's probably a letter signed someplace in our department by the chief of thoracic oncology and surgery that says we like testing to be done, we don't individually ask for any input. If you look at the NCCN guidelines, these happens to be the 2012, and I'm aware that there's a 2014 version. You see that the first thing that we're told to do is to establish the histologic subtype. And yet we're looking at recurrent or metastatic disease. And very seldom is there sufficient tissue to give a very good histologic subtyping. So what they're really trying to say to us without realizing is establish the cytologic subtype, because most of these specimens are actually cytology or small biopsy specimens. So there are problems in obtaining adequate specimens. I think we could talk about those problems for a long time. Most lung cancer patients will never come to surgery, and therefore we're left with this limited sample. And many pathologists are still in the comfort zone of working up these specimens with every immunostain known to man, and then being left with a very, very limited portion of a limited specimen to see what molecular analysis can be done. Now, the amount of material that you need also varies by the testing platform. Some platforms require more material than others. So these things have to be taken into consideration, and that's why the discussion should be with the pathologist, the oncologist, the interventionalist, etc. How much material do you need? People ask me this question all the time because people are under the impression that cytology is not suitable for molecular studies. That is completely wrong. Cytology is very suitable, and I give them kind of a flip, sarcastic answer, and I say 117 cells is what I need. What we did was actually count the tumor cells in a little study that we did, and our median number of cells was about 1,300, and the successful range in the specimens that we used was between 117 and 5,000 tumor cells. If you go down to less than 100 cells, it doesn't work. And of course, the platform matters. If you are going to use Sanger sequencing on which these mutations were initially identified, you need 50% tumor cellularity. 50% of the specimen has to be tumor. And if you have more sensitive methods, such as the sequenome, you can drop down to about 25. Now, next gen is going to ask for more. So you really need to know how it's going to be analyzed. Pathologists like to look at the microscope and say, with the aided eye, we can make a lot of determinations. And in fact, when we asked pathologists to just look at slides of tumor using the light microscope and say, is this adequate or is this not adequate for mutational analysis? Surprisingly, with rare exception, when the pathologist eyeballed it and said it was adequate, it was adequate. So the corollary to that is if the pathologist says it's not adequate, it probably is not adequate. But you don't necessarily need to get super fancy in how you quantify the material. Our acquisition is done very carefully when we're dealing with small bits. Everyone at Memorial is tested for the presence of certain mutations, most often EGFR, KRAS, and ALK, regardless of stage, regardless of intended therapy. We see the specimen and we test it. Now, I get some criticism sometimes because people say, why are you testing, operably cured stage 1s? You should wait for recurrence, etc. I think that's an individual local decision, and we test whatever comes by. We do not reflexly test cytology material. Why don't we do that? Not because it's inadequate, but because we don't know what's going to happen next. And sometimes it's determination of extent of disease, sometimes it's the initial sample that will be resected next week. So since we know so little about them, we don't routinely do it. If asked, of course we will. Now, all of our procedures, interventional, radiology, EBUS, bronchoscopy, FNA, etc., are attended. They're attended either by a cytotechnologist with years of experience or by a cytology fellow. Occasionally, the attending will go down if there's some kind of issue. That tissue is analyzed for adequacy. Is it enough to get out of it what I want to get out of it? Not is it cancer, is it not cancer? Is it enough to work up? And that's where we start our triage. If it's not enough, we say, okay, I know you're going to want X, Y, and Z. Dr. Pack is in the audience. He likes us to get lots for squamous. He'll talk about that. So we say, okay, if Paul's on, we better get more. If we think it's lymphoma, we're going to take enough to get that through flow, etc. So that's where we begin. So that's why we don't have too many unsats to deal with. Now, it does happen that the interventionalists will say, I can't do anymore. Patients just collapse the lung, blah, blah, blah. That's a technical medical call. But we will tell people, go back, get more, this was lousy, etc. And there are no procedures that are unattended deliberately. We don't often get information. So if you want us to be nice and help you, and if you're an oncologist or a surgeon, tell us what you want. And I know I always kind of annoy my colleagues at Memorial. Oh, great, you have protocol A, B, C, D, E written on the piece of paper, but I don't know what that is. So I don't know what you need. So if you tell me what you need, I can get you more. The communication is a key. So for example, if a patient has already been a responder to a tyrosine kinase inhibitor and has recurred, clinician's probably looking for a resistance mutation. But if you don't tell me that, or the patients come from the outside, I might waste all that going all through the EGFR all over again. So really, in order to prioritize tissue, you need good communications. We work in disease management teams. I spend all of my time with people who are interested in thoracic oncology. I never look at breast cancer under the microscope. That makes it easier. That doesn't work for everyone. Everyone's hospital isn't the same. If there's something that I do that's useful to you, by all means take it. If it makes no sense to you, forget about it. I certainly won't be offended if you don't copy what I do. As I said, we tend to do anything that we can't call squamous. We don't believe in routinely analyzing squamous cell carcinoma, and we do not routinely analyze small cell carcinoma. Now, that's not to say there aren't in special cases. Certainly there are. We also do something that is a little bit different. All of our tumors are also tested for ALK by immunohistochemistry, all of them that are not squamous. I even test small cells. I even tested them for a while to see what I would get. I got nothing, so I quit doing it. So all of our adenocarcinomas, the ones that we can't tell are not adeno, which is a very small number. We also tend to keep our large cell category under 10%. They're all tested by IHC. Now, right now, those cases are also moved on to FISH, and we're also using the double positives for validation of next gen. We're running them to see what's in there in terms of a deeper look into sequencing. So we can easily give someone an answer as to whether or not their patient has an ALK abnormality within 12 hours. That may not be the FDA companion diagnostic, and I am not going to comment on whether or not clinicians will treat on that, although I think I know the answer. So this is what we use. This is an example from Cytology using a cell block from an FNA of a lung. The middle panel shows you the cell signaling D5F clone. That's what we use. There may be others out there. That is ours. And the brown cytoplasmic stain is positive here. And then I have it coupled with the Abbott FISH dual color break-apart probe. I should also tell you, I didn't bring any pictures, but I should also tell you that we have EGFR mutation-specific antibodies for 19 and L858R. And while we don't routinely employ them, we certainly use them for things like CSF, where we have just a few cells or very, very limited amounts of material. Those IHC stains are terrific for conserving material or for using little bits of material. The problem with the EGFR stains is that positive is absolutely positive. Negative means nothing. So if you get a negative IHC on EGFR, more work needs to be done. However, we haven't seen negative ALK with negative FISH. So that's something that will help using tissue. We don't like IHC stains too much. We used to like them a lot, but we kind of moved away from them. Maybe a few people still tend to use a lot of stains. I do not. I do not encourage my team to use a lot of stains because you can level through a paraffin block very quickly doing IHC stains. What do we like? We like TTF1. It's a sharp nuclear stain. It's positive in lung adenocarcinoma. It's positive in a few other organ systems sporadically as well, but you need to trust us that we know what those are. We like P40 as a marker for squamous cell. Now, some people prefer napsinate. That's very good if you understand it's a cytoplasmic stain and don't get confused on cellular compartments. Some people like P63. I like P40 better. I don't think that there's a role for CK7 and CK20 in trying to identify an adeno or a squamous or a lung origin. Some people think that a strong CK7 will tell you that it's adeno, but I have seen that really not work well at all. Now, there are other stains such as 34-beta-E12 and CK56 that people use. I use them if I'm having trouble with what I call my primary stains and I want some additional support. But I would not use them as a go-to stain. They're not specific enough. You can have 34-beta-E12 staining in up to 30% of adenos. So you have to be very careful. You have to know how to weigh, pick and choose the stains. But right now, it's TTF1 and P40 are our current favorites. I could accept napsin A and P63 if that's what your laboratory likes to do. Here's an example of cytology material where we took, again, the cell block. These stains can be applied to direct smears, but cell blocks are easier. And here we have the nuclear staining positivity of TTF1 coupled with the negative P40. Now, I don't always do 2 stains if I think it's adeno, but I'm a little weak on that. I'll just do a TTF1, and if it's strong enough, I won't even do a P40. And conversely, I will show you what that looks like. There's your P40, and it's staining this cytology cell block. And if you look at these cell blocks, you can easily get confused on the H&E morphology because for some reason, cell blocks always have a squamoid appearance. So there's a lot of pink cytoplasm in this adeno, and there's a lot of, it's slightly less pink in this stain, but pink cytoplasm in this squamous cell carcinoma. So we need to know what stains work for what. As I said, we assure adequacy by having someone present. Now, is it possible that we'll say something is adequate on site and then come back up into the lab and say it's not adequate? 99.99% of the time, no. What we say downstairs or upstairs, wherever your suites are, as adequate is adequate. Now, that doesn't mean that you're going to get a positive molecular result off that, but it means that we have enough material where we believe we can make the diagnosis and the additional studies. Keeping them honest. We do an incredible amount of QA. Every single thing we do is QA'd in cytology. Sometimes I'm sick to death of the letters QA. But what I'm afraid of is that we'll imprint into our minds something that's just plain wrong. So while I don't necessarily believe that tissue is the gold standard, that's about all we have. And with any cytology specimen or small biopsy specimen that is followed by a resection, it's automatically QA, QA, QA. We correlate our ALK IHC with FISH. And as a matter of fact, the information that we gather in our reflex testing is used for many purposes. We have thousands and thousands and thousands of cases that we have run through EGFR, KRAS, and ALK testing, and that allows us to get a better and a deeper look into demographics, patient profiles, unusual fusion partners that we would not be able to do if we didn't study everyone. Do we have trouble getting it paid for? So far, we have not.